then there'll be some handouts that you can take out as you're going out. First thing to think about is how we actually make relevant our imaging assessment. And you can only do that if you go back to the clinical, which is what Professor Funk was saying. Remember that laxity is not instability. I know it's silly to have to say that, but I find so many cases come with laxity, either on an EUA or clinically, without instability. This person is a Lucy, her shoulder wobbles all over the place. She's never had a day symptom from it in her life. She's not unstable. This patient also loose. She has an instability. She has a shoulder that is symptomatic. So instability is where the humeral head is not properly held on the glenoid during function and causes the patient symptoms. You can get a stiff individual that's unstable. You can get a lax individual that's unstable. This patient happens to be lax. Our task is to work out why this shoulder is unstable. I'll tell you why it's unstable later. Some of you will know by looking at the slide. So the assessment is basically clinical, then imaging based on the clinical, and you've heard what Professor Funk says about that. Arthroscopy, which is fundamental, in my view, to understanding instability, and then special tests. So the history is vital. That first dislocation, how did it happen? You've heard how important it is in the athlete, it's important in other people. This patient came with a lax shoulder. It was symptomatic, it was unstable. He was referred for an operation because the shoulder was falling out of joint. It was so unstable. But if you went into the history, he supposedly injured it trampolining. But actually the first dislocation occurred a little while after the injury trampolining. He turned out to have a muscle patterning instability. He was holding his shoulder out of joint with muscle action. We gave him pentothal. We further relaxed the muscles that should have been holding the shoulder in place. And the shoulder went back into place. Because, unknown to him, involuntarily, his shoulder was being held out of place by muscle action. You operate on him, it will fail, and you will give him an early onset arthritis. It was all in the history. You've heard about the examination, and you all know how to examine the unstable shoulder. I won't go into that. Radiographs can be as useful as the more advanced imaging techniques. A Stryker projection radiograph will show you we call it a Broca defect in the UK, because Broca was an Englishman and described the posterior humeral head defect long before Hill or Sachs. But as you will notice, the Hill-Sachs lesion, at the back of the humeral head, you know that there is a structural anterior instability. You may want to do a CT scan to work out what sort of surgery to do. But the X-ray gave you the diagnosis. So don't throw X-rays away. If you want to get really subtle information, do a bilateral Stryker to compare one side with the other. Then you can make sense of very subtle defects. We've heard about CT scanning. We've heard about MR. I agree entirely. MR arthrography is the most important thing. MR shows you the soft tissues. This patient had an unstable shoulder. Actually, my arrow will work outside. But you'll see there's quite a big pouch. Will it reach? No, oh, it will. Look. There you go. So at this level, you'll see that he's got quite a big pouch. that was interpreted as a bank heart. But actually, if you went back to the history, this patient had an atraumatic dislocation. He was down the right-hand bottom end of the triangle. There wasn't an injury. It not pulled the capsular labral structures off the glenoid. He had a developmental bank heart. That can happen. Very difficult to deal with arthroscopically unless you can do really clever soft tissue plication. But this patient had a really soft tissue type of instability rather than a capsular labral disruption. All in the history. So we get focused on the scans, and as Professor Funk says, a radiologist comes along and interprets the scan that is one step removed from reality. The scan is not reality, you now get even further removed from reality. So think about your history in your interpretation of the scan. It's fundamental, and I can't believe that I'm having to say this. Many years ago, I was lecturing in Holland, and I told people that technology was going to lead us by the nose. And they said, yeah, listen to this old fogey. But it's happening all the time. I see people who are treated according to the technology, not to the history and the finding. For me, arthroscopy is fundamental. It gives you all the answers. Now, you don't want to arthroscope everybody, but if you've got any queries, arthroscopy gives you the answers. Clearly, if you've got a big bank heart, then that's obvious. But if you find absolute normality, although the shoulder's unstable clinically, be careful because that's likely to be a muscle patterning instability. Examination under anesthetic, I think, also leads you by the nose. People interpret laxity as being an instability. And if you put somebody under anesthetic, then you will get all the shoulder wobbling all over the place. That's not instability, that's laxity. And the only way of making sense of laxity is Bob Cofield's method, which was reported in Clinical Orthopedics. It's a very careful way of assessing the ligamental structures of the shoulder, and he only found it useful in a small proportion of cases. So EUA is not a very good way of examining and assessing instability. Electromyography is difficult. Some cases of muscle patterning instability are not that apparent clinically. You may need to do EMG studies that we have done over many years to work out if the muscles are being used in the right sequence. This is not EMG, is the muscle denervated? This is when does the muscle switch on? Does a patient use infraspinatus throughout the range of elevation? Or is infraspinatus switched off at a moment in the elevation, allowing the shoulder to dislocate backwards? You can sometimes pick that up clinically if you look very carefully, because you'll find as the patient takes the arm up, there'll be a little internal rotation, it'll come out and it'll go on up. But unless you're looking for it, you will miss it, and you will say this is an atraumatic instability. We will operate, and it will go wrong. So we did a lot of studies with needle electrodes and worked out the patterns, and we found that there's a group where the muscle patterning is not readily apparent clinically. I accept that not everybody can do needle electrodes. We tried to reproduce the same with surface electrodes, and that's quite useful looking at the muscles that you can access. Sometimes you can put electrodes on latissimus dorsi and find that it's active when it shouldn't be. You can't always pick it up with the same accuracy as you can with needle electrodes. But have the suspicion. If you have the suspicion in your mind, go to your EMG person or your physiotherapists and get them to do surface electrodes, looking at infraspinatus, latissimus dorsi, and pectoralis major mainly. There are other patterns, but that will help you. But not everybody has EMGs that they can do. The whole point about the assessment is to be able to classify that instability. If you can't classify an instability correctly, you cannot treat it correctly. So classification should be comprehensive, it should be simple to use clinically, it should be illuminating, and it should be reproducible between observers. It should differentiate between laxity and instability. It should differentiate multi-directional instability. If you take one message out of this room, multi-directional instability is not a diagnosis. It is a symptom. You can have a variety of pathologies that create multi-directional instability. Thus, I've now destroyed most of the papers that have ever been written about multi-directional instability, because they're all a mixture of cases. So the classification system should allow you to differentiate pathology that causes that MDI. Voluntary and involuntary, I hope are terms that have gone. Dismiss them from your mind. They're not helpful. One of the importance of classifications is that if you don't classify correctly, then of course your treatment won't work. And we looked at a series of anterior instabilities that had failed repair, published in the JPJs many years ago, before most of you were born. We showed that about 3 different causes. One was a misdiagnosis. So a third of cases were misdiagnosed. A third were the wrong operations chosen. And a third were the operation was done inexpertly. But misdiagnosis was a major feature. Professor Funks referred to the Matson classification very simply, very good, very sexy, very attractive. But all the classification systems fail to understand that more than one pathology can exist in the same shoulder. Professor Funks referred to that. Furthermore, as he says, the pathomechanics can change over time. So when you're faced with a case, you need to know, is it structural or is it non-structural? If it's structural, is it atraumatic or is it traumatic? So for many years, we've used what's known as the Stanmore classification system. And the value of this is that it combines the pathologies and the important things that you're going to find. At the top, there's a lot of trauma in that case. As you come down, there's no trauma. It's atraumatic. But more importantly, or as importantly, at this end of the triangle, it's pure muscle patterning. This side of the triangle, there's no muscle patterning. So it combines 2 factors, trauma and a lack of trauma, muscle patterning and a lack of muscle patterning. Now, when we did a survey of this, we found that there were lots of cases. We looked at about 700 odd cases. Alex Malone and Andrew Yagi actually did that survey for us. And you will find that the cases are actually distributed around the triangle. The most occur at the polar positions. This is all written about in this handout that I've given you, so you'll see that. But there are cases that occur along the triangle. They have mixed pathologies. And the handout will show you how to differentiate those. It's absolutely fundamental. Professor Funk says our interest has been largely in the muscle patterning instabilities, and out of that cohort, almost 50% were actually muscle patterning or had a muscle patterning component. The important thing about that is how does it help you with the treatment? Well, as we've seen, in the purely structural cases, the Taubes Ambry, surgery is highly effective in everybody, not just, and Professor Funk's pulled out the athletes. But you can get success rates, our own success rate was in the order of sort of 98% in that group. And that's not clever. Lost my arrow. Here. In the group 1-1-3, so there's mainly trauma, very little muscle patterning. Sorry, come to here. In the group 3 and the 3-1, with a lot of muscle patterning, surgery is absolutely contraindicated. If you operate on those and it goes wrong, and they do it in a large proportion of cases, you will destroy that shoulder. You'll have to do multiple operations on that shoulder, and the patient's life will be destroyed. In the, I lost my arrow. In the group 1-3 and the subgroups along this line, you can only do surgery if you show that the muscle patterning has been proven to be corrected. Now that's where this classification is important, because if you take the Ambry, you'll remember from the maximum classification, it says, if rehabilitation fails in the Ambry group, you can do an operation. An operation will be good. The trouble is, a lot of those cases will be down the bottom here. Again, I've lost my arrow. A lot of those cases will be down the bottom here. And if you operate on them, they will fail. Those are the cases where you say, no, the muscle patterning is still operative, is still working, we cannot operate. Sorry, but we'll do you harm if we do. And here's a case in point. This young woman had a dislocation of her left shoulder frontwards. The surgeon said, okay, it's failed an Ambry, I'll operate on it. He operated on it, shoulder continued to dislocate. He said, oh, silly me, it's a posterior instability. It was. I'll operate at the back. Operated at the back, she still had an instability. She then started dislocating at the front on the right side. And the surgeon said, okay, we'll repair that. He repaired it, shoulder carried on dislocating. The surgeon said, oh, silly me, I got it wrong again, it's a posterior dislocation. I'll operate on it. Well, that patient did have a multidirectional instability. It was purely muscle patterning. And she needed rehabilitation to re-educate her muscle patterns. That's not the surgeon's fault. The classification system failed the surgeon. That's the whole point about getting a proper classification system. For those cases, rehabilitation is the way forward.